adjuvant treatment in adult cerebellar glioblastoma, a systemic review and meta-analysis of survival outcomes. So Khalil, thank you for being here. We're looking forward to this afternoon in your discussion. So without further ado, please take it away and share your slides. And as a reminder for those listening in who are participants tonight, if you have any questions for Khalil or the other panelists, please drop them in the chat and we will get to them at the end of this presentation. Khalil, take it away. Thanks for being here.
No problem. Thank you very much for that introduction. Okay, good day, everyone. My name is Khalil St.Brice. I'm a final year medical student at the University of the West Indies, St. Augustine, located in Trinidad and Tobago, which is in the Caribbean. Thank you for having me to the Seattle Science Foundation and Journal of Neuro-Oncology, Dr. Sheehan, Dr. Shepard, Hannah, Dr. D'Amico, and Dr. Cifarelli, and thank you all for the opportunity to discuss this work. It's an honor to be here, and I'm excited to present our research. I'll be discussing our publication titled Extent of Resection and Adjuvant Treatment in Adult Cerebellar Glioblastoma, a systematic review and meta-analysis of survival outcomes. I'll walk through why we did this, what we found, and what it may mean clinically. These are all the co-authors as well as the affiliations for our study. I have no disclosures. And this is our study that was published. So cerebellar glioblastoma is a rare subtype of glioblastoma and accounts for less than 1% of glioblastomas. So most of the literature ends up being small retrospective cohorts and case series, and even case reports. In real-world practice, cerebellar glioblastoma is often treated using supratentorial glioblastoma protocols, but recent studies have shown that cerebellar tumors have increasingly recognized molecular differences. What we kept running into in the literature was that survival data was limited and inconsistent, and there wasn't robust pooled comparisons looking at treatment strategy, especially extent of resection and adjuvant therapy. So the management question remained unsettled. What should we prioritize when we're making decisions for adult cerebellar glioblastoma? This takes us to one of our core clinical questions that really motivated this project. What truly drives survival in adult cerebellar glioblastoma? Is it extent of resection or is it chemoradiotherapy? When you look across the published cerebellar glioblastoma literature, treatment approaches are not uniform. Providers do not consistently apply full multimodality therapy, and in some series, management appears less aggressive compared with supratentorial glioblastoma. At the same time, prior studies report conflicting conclusions, some emphasizing aggressive surgery, others highlighting the importance of adjuvant therapy. That uncertainty is what led us to systematically pool patient-level data to directly evaluate the impact of surgery and chemoradiotherapy on survival. And then there are the two bigger picture questions that we also wanted to explore. Do cerebellar glioblastomas demonstrate different molecular profiles than supratentorial glioblastomas? And also, does MGMT promoter methylation carry the same prognostic meaning in cerebellar glioblastoma as it does supratentorially? Now, moving into the methods, this was a PRISMA individual patient data compliance systematic review. We searched PubMed, Embase, and Web of Science, and the search ran through April 2025. This slide shows how we kept the data set clinically meaningful and methodologically consistent. For inclusion, we required adults, so patients greater than or equal to 18, histologically confirmed cerebellar glioblastoma. We also adhered to the WHO 2021 classification framework of glioblastoma, meaning IDH wild-type status when reported, and we excluded any reported IDH mutant tumors. And critically, the study had to report either extent of resection and or chemoradiotherapy at the individual level, and it had to provide overall survival outcomes as well. For exclusion, we excluded pediatric, brainstem, as well as pooled infratentorial cohorts that did not stratify cerebellar glioblastoma. Patients that did not have overall survival data, as well as patient studies with less than 3 patients, as we wanted a larger data set, among others. This is our supplemental figure here, as you can see. Here's what we actually extracted and how we analyzed it. On the data extraction side, we captured demographics, age, sex, and tumor location, which would either be cerebellar hemisphere or the vermis. Karnofsky performance status, extent of resection, which was either gross total resection, subtotal resection, partial resection, or biopsy. And whether patients received chemoradiotherapy versus monotherapy. We also extracted molecular markers when they were available. Specifically, we looked at MGMT, TP53, and EGFR. And our primary outcomes were overall survival and progression-free survival. The key point here is that instead of doing only study level pooling, we rebuilt an individual level data set from what was reported. So we can run Kaplan-Meier analysis and Cox models on patient level variables, like extent of resection and adjuvant treatment, while also adjusting for anatomical, clinical, and molecular confounders. For analysis, we first summarized survival using Kaplan-Meier curves. And compared groups using log-rank testing and Wilcoxon testing when applicable. Then we did one-stage individual patient data, Cox proportional hazards models, to estimate the hazard ratios for key comparisons. And importantly, because treatment effects can be distorted when you just pull everything at one data set, we also performed a 2-stage random effects individual patient data meta-analysis. Risk of bias was Joanna-Briggs Institute checklist, and we ran statistics on JUMP Pro 17 and R version 4.4.2. Now moving into the pooled cohort, across 113 adult patients, which spanned 13 studies, the mean age was 54.9, and about 64% were male. In terms of location, most tumors were in the cerebral hemisphere, as you can see in the diagram, and 32% involved the vermis. Those weren't mutually exclusive in every report, as some overlapped in many ways. But for extent of resection, gross total resection was 37%, subtotal resection 11%, partial resection 43%, and biopsy was only 10%. So right away, you could see that partial resection was actually the most common category, which fits the idea that anatomical and surgical mobility can constrain what's feasible within the posterior fossa. This slide gives the headline survival estimates for the full pool cohort. For the entire cerebral glioblastoma cohort of 113 patients, the median overall survival was 9.3 months. The median progression-free survival was 7 months. If we look at landmark survival rates, for overall survival across 7, 6, 12, 18, and 24 months, it was 61.4, 42.6, 33.3, and 22.4. For progression-free survival, it was 57.6, 34.9, 19, and 16.9% respectively. So overall, this reinforces that adult cerebral glioblastoma behaves aggressively, and the outcomes, at least in this pool dataset, remain poor. Now, we stratified overall survival by extent of resection. The median overall survival numerically increases as you move from biopsy to greater resection. Gross total resection was 14 months, subtotal 12, partial 7.8, and biopsy 3.5. But the important part is when we compared all groups overall, it was not statistically significant. However, when we use Wilcoxon test, which emphasizes earlier survival differences, there was early separation when comparing gross total resection versus biopsy, which was statistically significant. This finding potentially reflects the clinical benefit of debulking and relief of mass effect in the posterior fossa, where surgical decompression can have a pronounced impact on clinical course and outcomes. Next, we looked at progression-free survival by extent of resection. This was not statistically significant, but you can see the trend here. Now, this is where the signal becomes very clear. When we stratified overall survival by adjuvant treatment approach, chemoradiotherapy showed a statistically significant survival advantage over monotherapy, with monotherapy being either radiation alone or chemotherapy alone. Median overall survival was 18 months with chemoradiotherapy, compared with 7 months with monotherapy. At 12 months, survival was 68.3 with chemoradiotherapy versus 30.7 with monotherapy, and a downward trend at 24 months. Here's the same comparison, but now looking at progression-free survival, With chemoradiotherapy, median progression-free survival was 12 months compared with 2.5 for monotherapy, which again reached statistical significance. Across every time point, chemoradiotherapy consistently outperformed monotherapy while reaching statistical significance. So not only are patients living longer with chemoradiotherapy, they're also maintaining disease control for much longer. When we looked at the data using unadjusted Cox proportional hazard models, the strongest signal again came from chemoradiotherapy. Patients who received chemotherapy had a hazard ratio of 0.49 compared with monotherapy, which translates to a 51% reduction in the risk of death. And this association was statistically significant, reinforcing what we were already seeing in the Kaplan-Meier curves. In contrast, when we examined the extent of resection, none of them, the comparisons reached statistical significance. Whether it was gross total resection with subtotal resection, partial resection, biopsy, or even incomplete resection, which we pulled together to account for the varying reporting of extent of resection across studies, particularly in the pre-rano era. So even before adjusting for other variables, surgery alone was not emerging as a dominant driver of survival, whereas chemoradiotherapy clearly was. To make sure these findings weren't being driven by a single study, we also performed the two-stage individual patient data meta-analysis. This means we calculated study-specific hazard ratios first and then pooled them using random effects modeling. So here you can see for chemoradiotherapy versus monotherapy, the pooled hazard ratio was 0.28, which corresponded to a 72% reduction in the risk of death. This comparison once again reached statistical significance, while for gross total resection versus incomplete resection, it was not significant. So across both modeling strategies, one-stage and two-stage individual patient data, chemoradiotherapy consistently emerged as a dominant survival determinant. This table really brings together the main findings we've been walking through across the survival curves and models. It also highlights some important clinical trends we observed. For example, in hemispheric tumors, they consistently performed higher compared with vermeil tumors. And also for Karnofsky performance status, it was greater than or equal to 70, consistently outperformed KPS less than 70 across all time points. And also, when we examined MGMT methylation status, we saw a non-significant trend towards better outcomes in the unmethylated tumors, besides at 18 months. And the previous two were also not significant. So in this study, we can see that the prognostic impact of MGMT methylation status appeared much less clear than what we typically see in supratentorial glioblastoma. When we looked at prior studies examining surgery in cerebellar glioblastoma, most have suggested that more extensive resection is associated with improved survival. Earlier work by Jalilian and Hall in 1998 reviewed malignant cerebellar glioblastomas and showed that patients who underwent surgery of a biopsy had prolonged survival in keeping with our study. More contemporary series, such as Sung and Gomez et al., reported longer overall survival with gross total resection. Population-based data, including Adams et al., also identified gross total resection as a prognostic factor. So histologically, the field has leaned towards aggressive cytoreduction whenever feasible. And what our findings suggest, however, is that while surgery remains a critical for diagnosis and tumor debulking, the survival advantage appears clearest when comparing surgery with biopsy without a consistent proportional benefit across increasing extent of resection. In other words, beyond cytoreduction, surgery alone does not seem to be the primary driver of long-term survival in this disease. In contrast to surgery, the benefit of adjuvant therapy has been consistent across the literature. Multiple studies have shown radiotherapy to be independently associated with improved survival. Others have demonstrated that both radiation and chemotherapy significantly prolonged overall survival. Even in pediatric glioblastoma series, combined chemoradiotherapy has been associated with dramatic improved survival improvements. So across institutions, populations, and age groups, the signal has been very clear: adjuvant therapy matters. What our data reinforce is just how strong and consistent this effect truly is. So the clinical message is chemoradiotherapy is the cornerstone of cerebellar glioblastoma treatment. When examining molecular features in our cohort, several striking patterns emerge. We observed MGMT promoter methylation in roughly 39% patients, TP53 mutations in 63% of patients, And notably, we had no cases of EGFR amplification. This molecular profile closely mirrors prior cerebellar glioblastoma studies. Earlier work such as has shown that TP53 immunopositivity and absence of EGFR amplification in cerebral tumors, essentially the reverse of what we typically see in supratentorial glioblastoma. In the study I have here, Cho et al., it further demonstrates higher rates of platelet-derived growth factor receptor alpha alteration and ATRX mutations in cerebral tumors compared to supratentorial glioblastoma. Together, these findings strongly suggest that cerebral glioblastoma may represent a biologically distinct entity rather than a simple location variant of conventional glioblastoma. Together, these findings strong, and although MGMT methylation is a powerful prognostic tool in supratentorial glioblastomas, we did not observe that trend in cerebral glioblastomas. And this may be attributed to the limited reporting and small numbers preventing a clear survival association, which highlights the need for larger molecularly annotated studies in this rare population. As with any study, in a rare disease, several limitations are important to acknowledge. Despite cerebral glioblastoma, it's very uncommon, and despite pooling across studies, our total sample size remained relatively small, which limited subgroup analysis and increased sampling variability. Molecular variables were incompletely reported across studies, restricting the ability to perform fully adjusted multivariable models and potentially introducing residual confounding. There was also substantial heterogeneity across studies in diagnostic criteria, treatment protocols, as well as in the duration of follow-up. We intentionally excluded studies that lacked stratified data, whether it's extent of resection, chemoradiotherapy, or overall survival. While it's reduced the number of eligible studies, it was necessary to ensure methodological consistency. Additionally, variation in how progression was defined across eras may have influenced progression-free survival estimates and also selection bias, which is very important. This likely exists particularly because patients who did not receive chemoradiotherapy may have had a poor baseline functional status or a higher tumor burden. Despite these limitations, this represents the most comprehensive and up-to-date patient-level analysis of adult cerebral glioblastoma to date. So in conclusion, chemoradiotherapy emerged as the only consistent and independent predictor of improved survival. Survival benefit of gross total resection was primarily evident when compared with biopsy alone. No clear survival advantage was observed with increasing surgical extent beyond debulking with surgery versus biopsy. And this reinforces once again that radiotherapy as a cornerstone of cerebral glioblastoma treatment and should be prioritized even when complete resection is not feasible. I'd like to take a moment to sincerely thank the mentors and collaborators who made this work possible. In particular, I'm incredibly grateful for the team at Massachusetts General Hospital, Dr. Parker, Dr. Nahed, Dr. Choi, Dr. Wang, Dr. Dietrich, and Dr. Marcus Cano for their mentorship, guidance, and constant support throughout this project. This project would not have been possible without their expertise, and I'd like to also thank my co-authors, Kim and Edgar, for their important contributions and collaborations, and I'm very grateful to everyone involved in this project. This is my contact information. And any questions?
Great talk and really very comprehensive, rigorous assessment of cerebellar glioblastomas and the role that the extent of resection plays, but also the chemoradiation role that is played as well. I thought you did a very nice job of assimilating the studies and really thoughtfully outlining some of the limitations. I wonder, given the literature and the challenges around the statistical power of the study that you did and the logistical challenges of coming up with a study that may be adequately powered, can you give some suggestions about how one might try to better define the value proposition of the extent of resection? Were you perhaps say for instance, where you have perhaps thinking about registry-based studies or large multi-center studies that could be undertaken? Because it would seem to me that the challenges around getting adequate statistical power to do subgroup analysis may be problematic.
Yes, definitely. That's a really good question, Dr. Shian, and it is something that we thought about as well. It's something that is very important for the future directions that that future studies could build upon as our study, with our study as a landmark. Hopefully, it would be ideal if we have future registries, like you said, population-based studies, or even clinical trials could potentially identify cerebral glioblastoma to more treat it as a separate biological entity. As when I was doing the research, that's really what I came across, that I think that we should start treating cerebral glioblastoma not necessarily as a subset of glioblastoma, as most, if any, it barely has any, if any, trials that actually specifically talk about cerebral glioblastoma. Most of them extrapolate cerebral glioblastoma in the context of glioblastoma trials. And I think that moving forward, we should really start to look more at management of and studying glioblastoma separately when it comes to molecular profiles, when it comes to the treatment. In some studies, they talked about as I said in the study, the EGFR immunonegativity, and as well as the TP53 immunopositivity. This significantly affects the treatments, as we see things like MEK inhibitors in drug trials, have shown good benefit in cerebral glioblastoma, while EGFR inhibitors have shown to be very ineffective in this population because of the fact that they are EGFR immunonegative. And we also need volumetric analysis rather than categorical extent of resection, classifying patients as gross total resection or partial resection based on surgery report or even post-operative thresholds, particularly within this RANO era, where we could better quantify it based on contrast enhancing and non-contrast enhancing tumor removal. This is something that we could also seek to extrapolate to cerebral glioblastoma, as is already being done in supratentorial glioblastomas. And because again, as you said, because it's prospective registries are critical, because this tumor represents less than 1% of glioblastomas, and single center series will always be underpowered. And a collaborative posterior fossa glioblastoma consortium with standardized definitions, imaging protocols, RANO-based progression criteria, and molecular profiling, again, would substantially improve interpretability. And adjusting for, sorry.
No, I was just saying, I agree with your point, and I think, as you've indicated, it is such a relatively, it strikes me as being a distinct entity at times from supratentorial glioblastoma, that is cerebellar glioblastoma, and obviously the relative rarity of it makes it a challenge to study. And so that's why it's important to do the studies that you've done, and potentially to set up frameworks for future studies, be it registry-based or multi-center cooperative groups or other things that may be able to come up with a better answer in terms of the value of extent of resection. And you're quite correct. All the rigorous methodology in terms of volumetric assessments and things need to be done if we're going to undertake that. But wonderful study. Dr. Shepard, do you have a question perhaps?
No, I think it's I think the study speaks for itself, so Khalil, hats off to you. Sure, there's a lot of meta-analyses that are performed, and I think you've done a really thorough job. And this is a really like a good model of how meta-analyses probably should be performed and submitted to the JNO and other journals. And I agree with your points and Dr. Sheehan's perspectives that, to me, posterior fossa glioblastoma has always been just kind of hard for me to wrap my head around, to be perfectly honest. It just always seems like a little bit of a different entity. So I think your data nicely points that, and gives data to that. I wonder, as a budding neurosurgeon and someone who will be taking care of these patients one day, I'm curious, what you and maybe your co-authors think about, tackling these patients. If you see someone in with what looks to be a cerebellar glioblastoma, are you going to try to take it all out? Still, even though you have this nice data, I always like tumors out rather than in. If I can do it safely. I'm just curious what your discussions have been with some of your co-authors on this.
That's another really good question, Dr. Shepherd. And yes, that's very true. And I think each case has to be a case-by-case basis when it comes to neurosurgery. It's as you would know better, not everything is a one-size-fits-all picture. And I guess I'm still very far from that point in time, but our data does suggest that gross total resection showed a survival advantage primarily when compared to biopsy, not a clear gradient beyond that. And that tells me the major benefit may come from debulking, and functional matters enormously in this disease. When searching the literature, I actually noticed that the reason why a lot of these patients did not receive the same adjuvant therapy as supratentorial glioblastomas was because patients cited a poor quality of life as the reason why they didn't undergo this adjuvant therapy. And that's another important consideration when it comes to extent of resection, particularly in terms of location, whether it's in the vermis or hemisphere. But surgery timing is important, and it's a part of the multimodal strategy. And the cornerstone remains adjuvant chemoradiotherapy, and surgery should optimize the patient's ability to receive it. So if a tumor could be taken out, I would never be against taking it out, as you said,
All right, I like that answer. No,
Well, that we try. I'll channel Randy, who's not here, but we do try to keep these conferences short. The attention span of our audience suggests that at about 30 minutes we should wrap things up. So with that, I think we'll conclude what was an amazing presentation. Well done. I will echo Dr. Shepherd's comments. This is how we'd like to see systematic reviews and analyses done, and you did a fantastic job, Khalil. Hopefully there'll be more to come. Looking forward to having you back on Tumor Talk and seeing more submissions and to JNO and publications from you and your group. Thank you so much.
Dr. Gian. Thank you, Dr. Shepherd and Hannah. Thank you. It's a pleasure to present today, and I'm really honored to be here.
Well, good luck.